This is my presentation on lung cancer. Lung tumors almost always start in the spongy pinkish gray walls of the bronchi, the tubular branching airways of the lungs. More than 20 types of malignant tumors that originate in the lung itself. The major types are small cell lung cancer and non-small cell lung cancer. Small cell lung cancer is more aggressive, meaning it can spread quickly to other parts of the body early in the disease. It is strongly tied to cigarette use and is rare in non-smokers. Non-small cell lung cancer grows more slowly and is more common. It is responsible for almost 85% of the lung cancers. The first modality I will discuss is ultrasound. Ultrasound is not used to detect lung cancer because it does not see through air, and the lungs are air. However, sometimes when a person has lung cancer, they also have a fluid buildup. Ultrasound is great to see the fluid buildup and can help doctors during a thoracentesis. The next modality is CT. A CT scan reveals the anatomy of the lungs and surrounding tissues, which our cancer doctors use to diagnose and monitor tumor growth. A CT scan creates a 3D picture of the lungs, but it can miss small tumors if part of the lung has collapsed, as is sometimes the case. A type of scan called a spiral CT may pick up early lung cancers in some people, but it's not clear whether it finds them early enough to save lives. Lung cancer will appear as a mass of some sort on a CT. When scanning a lung in CT, you perform a chest CT. It usually takes about 10 minutes from the time the patient enters the room until they leave. First, 2 scout images are taken, a AP and a lateral. Usually, contrast is not given unless doctors suspect the tumor or the mass have a vascular system to it. Then IV contrast would be given. The contrast given would be IsoVu. The amount and injection rate would be based on the patient's weight. This is a coronal view of the lungs. Here you can see a large mass on the patient's right side. This is an axial image of the lungs. The slice thickness is 3 millimeters. The technique used was 120 kV and 100 MA. The image on the left shows a lot of fluid buildup in the lung, and the image on the right shows the lung tumor along with the fluid. Here is the sagittal view. Here you can see the tumor and the fluid. Next, we have NucMed and PET scans. We do not use NucMed for lung cancer because the resolution is not good enough to see a mass, and NucMed focuses more on the functions of organs. However, we do use PET scan imaging to diagnose and treat certain cancers such as brain, breast, kidney, bladder, thyroid, liver, lung, and bone cancers. Nuclear medicine is a branch of radiology that involves administering small amounts of radioactive material called radiopharmaceuticals or radiotracers to a patient by injection, inhalation, or pill. The radiopharmaceutical eventually accumulates in a particular organ or area of the body where it gives off energy in the form of gamma rays. The energy is detected by a special camera which produces a series of images on a computer screen. This provides us with details about the structure and the function of an organ, tissue, or bone in the body. This test also allows us to identify abnormalities early in the progression of the disease. The hot lab is a radiation area and is restricted. It keeps all the radioactive injections in a safe area. Employees who are not nuclear medicine techs may not enter the hot lab unless they are accompanied by a NucMed tech or designated personnel. During a PET scan, the patient is first injected with a glucose solution that contains a very small amount of radioactive material. The substance is absorbed by the particular organs or tissues being examined. The patient rests on a table and slides into a large tunnel-shaped scanner. The gamma camera does not emit any radiation. The gamma camera is composed of radiation detectors called gamma camera heads, which are encased in metal and plastic and most often shaped like a box, attached to a round circular donut-shaped gantry. The first image taken is a scout image. The scout image is from the head to about mid-thigh. Next, a basic CT, which is not used for diagnostic purposes, is taken of the area of interest. Then, a PET image is taken. After all the images are taken, the basic CT and PET images are fused over each other, and that creates the fused images. PET scans are looking for dense highlighted areas. The PET scanner is then able to see damaged or cancerous cells where the glucose is being taken up and at the rate at which the tumor is using the glucose, which can determine the tumor grade. The coronal image shows the mass, which is highlighted in the lung region, in different stages of the scan. Here is the sagittal fused image. This shows the tumor highlighted from a side view. In the axial image, you can see the tumor highlighted as well as the fluid in the lung, which is not highlighted. The lung scan takes about 21 minutes. Just like with CT, there is a slice thickness. However, in PET, it's called the bed position. There are 7 bed positions for a lung scan, and each take 3 minutes. This is an image of a MIP. The MIP is used for detection of lung nodules in lung cancer screening programs, which utilize computed tomography scans. MIP enhances the 3D nature of these nodules, making them stand out from the pulmonary bronchi and vasculature. The images used in CT and PET were of the same patient. This patient was diagnosed with necrotic hypermetabolic mass involving the carinal region, a necrotic mass extending into the prehilar region. The mass is 11.3 centimeters. There is a right pleural effusion causing narrowing of the right bronchus. The right middle lobe collapsed completely and irregular densities starting in the left lung. Next is radiation therapy. Radiation therapy is the delivery of focused high-energy X-ray photons, gamma rays, or atomic particles. It affects cells that are rapidly dividing, such as cancer cells, much more than those that are not. Most cancers, including lung tumors, are made of cells that divide more rapidly than those in normal lung tissue, holding out the hope that the tumor can be eliminated without damaging surrounding normal tissues. Radiotherapy acts by attacking the genetic material within tumor cells, making it impossible for them to grow and create more cancer cells. Normal body cells may also be damaged, but they are able to repair themselves and function properly once again. The key strategy is to give daily doses of radiation large enough to kill a high percentage of the rapidly dividing cancer cells, while at the same time minimizing damage to the more slowly dividing normal tissue cells in the same area. Before your first visit, your cancer doctor will review your images and come up with the best treatment plan for you. This is a picture of the lungs that shows the radiation dose given to the location of the tumor. Each color line represents a different dose the area is receiving. The first radiation therapy session is a simulation. This is a practice run without giving radiation therapy. You will also be fitted for a mobilization device, which could include tape, foam sponges, headrests, and plaster casts. These will help you stay in the same position throughout each treatment. During the radiotherapy planning session, a permanent tattoo will be marked on the skin. This is used to help line up the radiotherapy machine for each treatment. This helps ensure that the same area is treated each time. After all the planning and preparations are complete, treatment can begin. Each session is quick and painless, lasting about 15 minutes. Typically, patients have treatment sessions 5 times per week, Monday through Friday. For lung cancer, this schedule continues for 3 to 9 weeks. Next is MRI. MRI does not utilize ionizing radiation. Instead, radio waves redirect alignment of hydrogen atoms that naturally exist within the body without causing any chemical changes in the tissues. As the hydrogen atoms return to their usual alignment, they emit energy that varies according to the type of body tissue from which they come. The MR scanner captures this energy and creates a picture of the tissues scanned based on this information. The magnetic field is produced by passing an electrical current through wire coils in most MRI units. Other coils located in the machine, and in some cases placed around the body part being imaged, send and receive radio waves producing signals that are detected by the coils. The electrical current does not come in contact with the patient. Jewelry and other accessories should be left at home if possible or removed prior to the MRI scan, because they can interfere with the magnetic field of the MRI unit. Metal and electronic items are not allowed in the exam room. In most cases, an MRI exam is safe for patients with metal implants, except for a few types. People with these implants cannot be scanned and should not enter the MRI scanning area. The coronal, axial, and sagittal images showed an irregular consolidation mass of about 1.2 centimeters in diameter at the posterior segment of the upper right lobe. The nodule was surgically removed and proved to be squamous cell carcinoma. Next is special procedures. Interventional radiology does not do much imaging for lung cancer. However, they do insert ports. A chest port insertion is a minimally invasive procedure during which an interventional radiologist places a device underneath the skin of the chest wall that allows your cancer care team to easily access the veins during future in- and outpatient encounters such as the infusion of chemotherapy, liquid antibiotics, IV fluids, and drawing blood for lab work. Here is a picture of a chest x-ray that shows the port. In conclusion, almost all of the modalities deal with lung cancer patients in some way, whether it's imaging to help the doctor see the tumor, or shrinking the tumor for possible surgery or patient comfort, or inserting a port to help with future chemotherapy treatments. Lung cancer patients will become very familiar with the radiology department.